Welcome, everybody. I want to wish you all a warm welcome to the second webinar on urbanization and yellow fever, hosted by the I program. Hopefully everyone is listening in their preferred language, and we'd like to thank you for making time to attend what promises to be an engaging and informative session today. We're fortunate to have speakers that will go over the guidelines for preparedness, readiness, and response planning to yellow fever outbreaks in an urban setting. We are delighted to be joined by these 5 guest speakers who we will introduce ahead of their presentations. We're hoping after the session that we'll be able to answer your questions. So as we go through each presentation, please put any questions in the chat. We'll compile them and we'll put them to the presenters. If we're unable to get to your questions today, we'll note them, work with the presenters to respond, and share back after the webinar as one of our follow-ups. Before we get to our first speaker, though, I'd like to introduce Dr. Jennifer Horton, who is the acting team lead for the I strategy. She's asked to say a few words of welcome, so I'll turn it over to Jen.
Good day and welcome to everyone online today. It's really a pleasure to see so many online in these first minutes of this webinar, and I'm sure that additional colleagues will be joining throughout. And also a great thank you to our speakers who we have lined up today, with a huge thanks to Dr. Peter Mabonje for coordinating not only the work to develop this guidance, but also in terms of the presentations that will be shared today. This is an important session and it's very relevant to yellow fever control, particularly in the context that we are facing today with a resurgence of yellow fever transmission and outbreaks that is affecting a wide geographic scope in Africa, and signals of ongoing spread in the sylvatic or jungle context in the Americas. Urban yellow fever is an ongoing and worrisome risk. Urban yellow fever outbreaks spread rapidly and affect under-immunized populations, and is particularly a risk in urban, crowded urban areas with which have low underlying population immunity. And we've seen the impact that this can have when the virus jumps from that more sylvatic cycle into the urban cycle, where it is transmitted by Aedes aegypti, a mosquito which is known for its capacity to bite and infect humans with yellow fever and other arboviral diseases, and to rapidly and be a rapid amplifier in that urban context. This was evidenced as recently as the significant outbreaks that actually occurred at the time of the inception of the yellow fever of the I strategy in 2016, where there was seen to be a huge outbreak in Luanda that had epicenter in Luanda, Angola, and then spread into DRC, impacting the urban centers of Kinshasa as well, and led to further additional spread through infected viremic travelers as far away as China. And this was really a stark wake-up call for the yellow fever control community due to the implications of these outbreaks and the necessity to leverage immense stocks of vaccine in order to respond, and really highlighted the import of urban preparedness, rapid detection, and response to any yellow fever signal, especially ones occurring in an under-immunized urban situation. So we're looking forward to the sessions today and are excited about this guidance that has been developed with the inputs of many countries, as well as many of our partners in the last 6 months or so. And then we'll also be interested in the discussion point of today's session and hearing your ideas in terms of how this can be rolled out on a larger scale into specific country contexts, and what you think might be necessary adaptations for specific countries or specific urban contexts. So with that, I'd like to pass back to Sydney with a huge thanks for facilitating the webinar today, and thank everyone online for joining. Over.
Lovely. Thank you, Dr. Jennifer. We appreciate the opening remarks. And so I'd like to move forward toward our first speaker. We're fortunate to have Dr. Blaise Batondeli from the World Health Organization's Africa Regional Office join us. and he's going to walk us through a presentation on yellow fever resilience from a regional perspective. After his presentation, we're actually going to take a subset of questions and do some Q&A, bringing Dr. William Kumakesh in, who's also representing the World Health Organization's Africa Regional Office. So over to you, Dr. Blaise.
Thank you very much. Hi, colleague, good afternoon. And I'm really happy to have this small presentation that I'm going to make during this call. The presentation is written and it will be projected in English, but I will be speaking in French, which is my first language. I'm still having, I will speak in French. OK, thank you. Merci beaucoup. Nous allons aller rapidement.
Thank you very much to everyone. We will quickly see a few elements on the situation of preparedness, of the yellow fever epidemics in urban settings, especially in the African region. We could underline that this activity is done through the I strategy, which is a strategy to eliminate the yellow fever epidemics, as you will be able to see. In my presentation, you will see that I will be speaking a lot about this I strategy, especially the roadmap in the African region to eliminate the yellow fever epidemics in Africa. I will also underline the preparation aspects and how it is included in the I strategy in the activities that are carried out in the whole African region. Next slide, please. Where did this I strategy come from in the African region? It started during the 2016 epidemics, which was managed and affected Angola and the RDC, as you know. Started in Rwanda and in Angola, and then was exported to Kinshasa, the capital of the DRC. So it's epidemics that touched both capital cities, with a few confirmed cases and a few deaths as well, with a very high fatality rate for this disease. Some cases were exported all the way to China, Mauritania, and Kenya. It was never seen before epidemics. So this is really from this epidemics that we started this I strategy, which was implemented by the Gavi, the UNICEF, and the WHO. In order that we just stop talking about yellow fever epidemics by the year 2026. As you know, during this epidemics, the vaccines that were available in other countries were gathered and for this epidemics, but we really had to mobilize the vaccines in these particular countries, meaning that the other countries didn't have access to those vaccines. So the lack of vaccines meant that we had to use only fractional doses. And from this risk and problem, this is where we decided to create the I strategy. This strategy eliminated, this strategy targets 40 countries in 27 in the African region. These were identified as high-risk countries for the yellow fever. And this strategy has 3 objectives: to protect at-risk populations, to prevent international spread, and contain outbreaks rapidly. And in the context that we are right now, during this webinar, we are trying to answer the second strategic objective, which is to prevent international spread. For which the African region decided to organize some activities in order to protect high-risk workers, especially the people who live in, for example, sylvatic regions, and immigrants as well, who are moving around the countries in order to look for a home or a work. These populations need to be protected against yellow fever epidemics in order to prevent the spread, but also to strengthen the application of health directives in countries. There's also building some resilient urban centers. When an epidemic reaches an urban center, it is a catastrophe. In Kinshasa, in Rwanda, it was a catastrophe, really. So we need to build stronger urban centers. So the African region knows already how to spread this information in order to have these very strong resilient centers in order to protect the population against yellow fever epidemics. For implementing this strategy in the African region, the strategy which was adopted in the Regional Committee for Africa in 2017. Next slide, please. The African region had a few objectives which came out from different elements that were viewed in Africa and challenges that were seen in Africa. Amongst which we note that in the African region, there wasn't really any center, very well-defined center in the urban centers where we defined the risk. So people were not very prepared. There was no preparation to answer these situations that can show up. We saw that in urban centers in Africa are popping up everywhere with the movement of population, rural exodus. And within those small rural zones now are starting to be small cities. So this organization is starting in order to really target the centers that are that would actually bring more spread of the vectors which are multiplying. So we don't even have a proper surveillance of the vectors. So it is a region that is not prepared enough. This is our main challenge here, meaning that our urban centers are always highly threatened and at high risk of developing a yellow fever epidemics. This means that when we adopted this eye strategy, the region had a few objectives, amongst which, by the end of 2019, we needed that all countries in the region will have initiated the implementation of the eye strategy, in which we find the preparation of urban centers for better resilience, in order that all centers are really able to prepare efficiently potential epidemics. So this is one milestone that the African region had really in mind in order to respond to that. And then we wanted that all the 27 at-risk countries could have those tools in order to prepare with labs, training, and also the strengthening of skills, but also have plans, have strategy in order to prepare.
Renforcer la routine, vacciner tout le monde, ça faisait partie des activités prioritaires qui ont été votées lors de la mise en œuvre de cette stratégie AI. Passez s'il vous plaît les slides suivants. Vous allez voir que parmi les activités...
Next slide, please. And here you will see the priority interventions that this region had. This highly resilient urban center with large priority activities that the region had in mind. And this is what the African region is really participating in all these initiatives, so that all the countries have a plan in place, a preparation, and to better respond these epidemics. So just to go a little bit faster, I won't be mentioning all of the points here, but just one priority that we have in our region, which is part of our roadmap and our regional roadmap as well, during the control for the control of the African region of yellow fever epidemics.
If we can skip this slide, thank you. So what does the African region do? It has an operational plan to implement the strategy, the eye strategy, on the region and support countries in order for them to be able to fight against outbreaks. And this operational plan spreads over the 3 strategic objectives of the eye strategy. Here, all activities are defined. These are activities that are being led by the region. This is the support that we're bringing to countries. All these activities are defined in this plan and answer to 3 strategic goals. In the framework of the protection of risk population, we thought about how we can vaccinate all those people in the risk zones, reinforce this vaccination in order to make sure that the babies born after the vaccination campaign could also benefit from vaccination. Countries who have not yet included yellow fever vaccination in their program can introduce them as of now. I'd like to highlight that we have 3 regions in Africa. It's Ethiopia, Uganda, and South Sudan, who have not introduced the vaccination yet. Uganda will do by July, but we continue to fight to make sure that the countries can include this vaccine in their routine program. Kenya is undergoing an outbreak at the moment, and we need to make sure therefore, to introduce the vaccine to cover all countries and all regions. The risk analysis of yellow fever will be done regularly for each country to make sure where the risk is and what measures are to be taken to make sure that all countries are protected from epidemics of yellow fever. Next slide. Now for the second goal, to prevent the spread of the outbreak, we make sure we talked here about the year 26. So by 2026, on the national level as well as international level. And if the region sets this goal to be able to protect all populations, apply measures corresponding to international healthcare rules, but also in the urban centers. So for the operational plan, the African region said that all countries of high risk need to have resilience centers, plans for prevention, and plans for response planning against these outbreaks. Therefore, all urban centers need to have time to make a risk analysis and also a checklist that needs to be followed at all times to make sure that the urban centers are ready to respond to an epidemic that could break out at any point. Many activities are already prepared in the operational plans to be implemented and to make sure that we can have a response ready. This is the plan today. We always try to move forward, improve resilience. Next slide, please. For the third objective, contain outbreaks rapidly. This is about surveillance, about reinforcement of labs, to make sure that the cases detected can be analyzed as fast as possible. And in an epidemic, that the response can be immediate. To get there, some things need to be taken into account. Next slide. To get there, to have a success in what we are preparing today and what the region has set itself as a goal, we really need commitment from all member states of governments to make sure that all governments participate. So this is what is being done in the region with all countries, all governments, to make sure that there is a firm commitment in order to eliminate yellow fever epidemics and in order not to talk about this anymore by 2026. Afro, just as all other partners, work together to support this goal. Today, we have an I strategy with a regional team, which includes all partners: UNICEF, CDC, Africa CDC, and all members of government, all governments of the member states, in order that altogether we can evolve in the framework of the respect of international healthcare laws, to be more resilient, and in order to make sure that if there is an outbreak, we are ready to answer, to have a response as fast as possible, and in order never to talk again about these yellow fever epidemics by 2026. I think briefly that's what we had to present to you. As we have a little bit more time, these are the broader lines, but maybe the detail will come with the questions. And if you want a detailed plan, we can share it as well with the participants in order that they can understand how the region is committed and engaged in this resilience program in order to make sure that all countries are resilient, in order to make sure that these activities that we lead for prevention, for readiness, for preparation can be implemented in all countries, and in order to make sure that all centers can answer to an outbreak. Thank you very much. That was the last slide for me. Thank you so much.
Thank you, Dr. Blaise. Thank you very much for that presentation. And I would just like to see if participants have any questions. If you do, kindly put them in the chat and we can review them with the presenters. If we see any in the next 30 seconds or so, we can field them right now. I guess I would be interested in hearing from the regional perspective, what other diseases are you drawing lessons from as you're working on resilience for yellow fever? So Dr. Blaise, Dr. Komukesh, if you would want to weigh in on this.
Good afternoon, everybody. We're happy to participate in this webinar. I think that is a very good question. As you know, yellow fever is one of the high threat pathogens, along with meningitis and cholera. So these are some of the diseases that we sort of learn from each other. But of course, now we are also dealing with other threats. So we have a lot to learn from other threats as well. COVID-19, for example. Thank you.
Excellent. Thank you. Thank you for that. And I'm wondering if Dr. Blaise has anything to add as well. So COVID-19 resilience seems to be an area we can learn from. Is there a specific element, either Dr. William or Dr. Blaise, is there a specific element of COVID-19 response that applies well to yellow fever?
Well, I think yellow fever, as probably we are going to learn when the guideline is unveiled, there are certain things that need to be done to prepare for a possible outbreak in the urban setting. Urban settings need to be prepared so that in the event of an outbreak, they respond swiftly to stop the spread. For example, through rapid vaccination of all those that are at risk. So urban centers need to be prepared, vaccines need to be available, and all the logistics need to be put in place. So I think these are some of the things that we shall see as the guideline is going to be unveiled. Thank you.
Excellent. Thank you very much for that clarification. And to expand a bit more, are there other arboviral disease outbreaks in urban contexts that have helped inform yellow fever?
I cannot immediately come out with viral diseases that had outbreaks in urban centers that informed the need to prepare and respond to yellow fever. As you know, yellow fever is actually a very old disease and has been around for centuries. So yes, the threat has been there, the burden has been known. So it probably other diseases will learn from yellow fever instead of the other way around.
I hear what you're saying. Yes, it's an opportunity for others as well. Excellent. Well, if other participants have questions, again, please put them in the chat. We'll use this opportunity to thank Dr. Blaise and Dr. William and move to our next presenter. Any questions you might have remaining, we'll consolidate, answer at the end of this session as time allows, and then respond over email. So I'm very happy to introduce Dr. Linda Eso from the Cameroon Ministry of Health. So Dr. Eso will be joining us to present on the challenges that they faced around resilience and response in an urban setting. And she will be presenting in French as well. So just a gentle reminder to participants that there's an interpretation button at the bottom of your Zoom screen, and you can select interpretation to the language of your choice. Over to you, Dr. Linda.
Bon après-midi à tous, bonsoir. Bonjour.
Hello to all. Hello, good morning, good evening, wherever you are. I hope you can hear me well. Yes, perfectly. Thanks very much for giving us the opportunity to present this presentation regarding the preparation and the response to yellow fever outbreaks in a urban setting, in particular in Cameroon. Next slide, please. So Cameroon is a particular country because of its population. We have an urban population of 56.4%, but we also have many cultures. We have many tribes, dialects, religions, and this means that this requires to have various approaches. According to the population we are aiming for with this response planning, because the response that we will have in the region will be different according to the country that we work with, to the region, sorry. Now, regarding the epidemiology of the situation in Cameroon, all regions are affected. We have 32 health districts that are in outbreaks at 16.8% of districts affected. We have 44 cases confirmed since 2021, of which 38.3% are not vaccinated, and we have a lethality level of 14.84%, so 7 from 47 people were deceased. Next slide, please. So in the epidemic that's on the go, we have many districts affected. 8 of them are urban health districts. So that's one case. That's many districts affected. And we have an urban residence of 30%. We led deep investigations in 8 health districts, and the vector that has been put in evidence in 3 districts. So we were able to see the movement of the disease in 3 from the 8 urban districts. So that means we can take action and take into account these actions for our country in order to control outbreaks in our country. Next slide. Now, for preparedness of yellow fever in our districts, we're not very advanced on that level. We don't yet have a specific plan to contain epidemics in an urban setting. We have a global answer for yellow fever that's undergo, but there is no specific planification for urban settings, and to take into account also the implementation of resilient urban centers. However, there is still things that have been done. We have taken part in the simulation exercises. They were organized by the WHO, but also in the framework of preparedness and readiness, we implemented the training of investigation teams and rapid intervention teams in April 2022, in particular for the containment of yellow fever outbreaks in an urban setting, because in the urban communities, it's more difficult to implement interventions and investigations because populations need to be willing to participate. So we also have a center of public health in which the management of the outbreak was centered in order to fight this outbreak. We also have many trained physicians on the field, whether it's on the basic, intermediary, or advanced level in all regions affected by the yellow fever epidemic. Now, on surveillance, we have a robust system for yellow fever with a recent adaptation and the adoption of the third edition of the CIMR, sorry. We can therefore reinforce also the surveillance on the level of the communities, but we also need to reiterate that the health districts and urban districts are not covered by this surveillance. The surveillance on case by case is also implemented with biological confirmation done by the Pasteur Center of Cameroon. Now, surveillance on entries. This needs to be reinforced. At the level where we are now, we need to be able to reinforce controlling, first of all, of entrance and exits with a card, but also for the health professionals that are on the borders in order for them to be able to follow up who goes in and out and who has been checked on the borders.
Regarding the routine immunization is efficient and has been taken into account in a large vaccination program. So we have normally a low vaccination coverage, but in 2022, in the first quarter, we had 43%. Even if the vaccination coverage wasn't really affected by the COVID-19 since the beginning of the pandemics, the figures in 2022 are quite low. In Cameroon, this epidemics mobilizes the health personnel, but also the people who vaccinate. So everything is put into everything is put together. We have campaigns for the polio, we have the yellow fever, we have and then the COVID-19 just got added to all these vaccinations. So these very, very low vaccination coverage can be noted in different health districts. But regarding the supplementary immunization activities in 2015, there was an active yellow fever campaign which was deployed in 54 health districts with a vaccination coverage of 98%. So I think we should have something else similar like that in our country. Next slide, please. Regarding the epidemics that is ongoing in our country, we have activated a management system within the hospitals and other centers with health centers that actually make sure that all of the centers can communicate. For example, different programs for vaccinating, for training, and the laboratories as well, and the Pasteur Institute in Cameroon and other institutions that are working in public health, and also for communication. We should also, even this works well, we should also pull together all the different sectors that could also help. For example, people in cities taking care of mobilizing financial and human resources, multidisciplinary and multi-sectoral approach to this. So we can see that there is a very weak implication of the different sectors. And this is why it's very important to have this platform in order to respond to the epidemics in urban settings. We can also note the preparation of the response, because the goal to have everything ready by 2026 isn't very effective here in Cameroon, and we can say that by looking at the way that the current epidemics is managed. So it's hard sometimes to mobilize all those resources, financial, human, in order to lead the investigations of the epidemics in the centers that are targeted, and also in health districts where we have a poor adherence of populations in the interventions. For example, when we have to make samples or when we actually suggest vaccination. In the health training, the training and other trainings are not very validated by the institutions. We need to put into place some protocol to really make sure that all of the health personnel and in all health districts have access to the same information, and make sure that we lower the risk like that. We also have weak capacities when it comes to vector control. During when I made this presentation, we have a campaign which can act as a vector control campaign in order to fight yellow fever, but it's a low coverage in urban areas. And for the moment, for all health districts in urban settings are not actually touched by the next campaign, which is being developed and will be deployed in the next 2 weeks. Next slide, please. Regarding the response to these epidemics, there is one vaccination campaign which is activated in the last 3 weeks and until the 15th of June, and 3 of our 8 health districts in urban settings are touched. It is hard to put into on disposal the vaccination doses, especially in the coastline and different regions with a high in all the centers with high density population where the vaccination campaign is active. We have also on the board, we also have airports, and we need to check at the borders and at the airports as well that everyone is being checked. And this is also where we really managed to put into place this active campaign. Regarding the community involvement, it's really hard to really raise awareness and make campaigns in urban areas, whether it is on the population, but also on the institutions. There's also the COVID-19 and the cholera, and there at the moment more they get more press. So it's really hard to really raise awareness for yellow fever and for communicating really the risks. And we are lacking this support in order to really deploy larger campaigns in urban areas. So this is our situation regarding yellow fever here and the response that we bring in our country to this risk in urban areas in Cameroon. And I thank you very much for your attention.
Thank you so much, Dr. Linda, for going through that presentation. We're going to collect comments and questions in the chat. So if participants could kindly enter any questions they have for Dr. Linda, we will get to them at the end of this series. So we are fortunate to have a second speaker, Dr. Emeline Bois, who represents the Ministry of Health in Côte d'Ivoire, to also present challenges that they have experienced. Just a gentle reminder to our speakers, we do have interpreters on the line so that we can have a truly global conversation. So kindly speak slowly so they can keep up with you. And also just a quick reminder as well that we are trying to wrap up here in probably 10 to 15 minutes on this presentation to leave time for discussion at the end. So with that, over to you, Dr. Emily.
Merci, bonsoir à tous. J'espère que vous m'entendez.
Thank you. Good evening to everyone. I hope you can hear me perfectly. I have this opportunity to present the challenges that we have in preparedness and response to epidemics of yellow fever in urban settings in the Côte d'Ivoire. Next slide, please. We have to say that the yellow fever in Côte d'Ivoire has been there for a long time. In 1977, we had cases already, and then since 82, we already had very large epidemics. We had one in Bambayako, and since 2001, we have resurgences of the epidemics in Abidjan and inside the country. This graphic shows you that in 2021, we had a very large epidemics and we had a vaccination campaign. And every year that followed, we also had epidemics all the way to 2008. Next slide, please. In 2008, we had to really assess the yellow fever risk. Right now, at this time, Côte d'Ivoire had 83 health districts, and we had 64 at-risk health districts in terms of the high yellow fever risk. So in 2009, we started a new campaign in Abidjan. We had to vaccinate 2,229,026 people on a population of 4 million. From 2011 until 2012, we had another campaign, prevention campaign that took Côte d'Ivoire as a whole with 95 vaccination coverage. In 2019, we had a high number of cases, which were IgM positive, and we have to really evaluate this risk. And we understood there that we were not really in an epidemic, so there was no vaccination campaign. Since 2021, we realized that we had more cases, but to this day, we are not we don't have an ongoing epidemics. In 2021, we had 21 positive cases. And since the beginning of the year 2022, we had about 20 cases that were positive. Next slide, please.
Au niveau de la réponse pour la coordination de la gestion des épidémies.
So regarding the response to managing these epidemics, the emergency health response in Côte d'Ivoire, we were able to have a multi-sectoral response. We had different levels in which we can reply, which can be just surveillance to alerts to response and activating the COUSP. But as I was saying, up until now, the Côte d'Ivoire did not have an epidemics of yellow fever. Next slide, please. Regarding the epidemiology surveillance, we can say that we have a very comprehensive surveillance in all of the health districts. We have 113 health districts. and they all have a surveillance of yellow fever. And the detection of suspected cases in health facilities and in the community use the definition of suspected cases to see which level we are at. And the collection and forwarding of samples to the reference laboratories, we have to note that we have a reference lab, which is the Institut Pasteur in the Côte d'Ivoire, which analyzes all the samples of the country. And the notification of cases is through electronic means through an app called MAJP. Next slide, please. As I was saying, all the samples are led to the reference lab at the country level. And when we have positive cases, they are then confirmed by the Institut Pasteur in Dakar. Then we investigate around those cases, and then we make an entomological survey at the National Health Institute. And this can really help us assess the risk around the cases and then classify this case. Up to this day, we've only had sporadic cases. Next slide, please. Regarding the management of the cases, it is done in all of the health centers, and very serious cases are transferred in larger hospital centers, for example, the regional hospital centers. We also have a service of tropical and infectious diseases, where we also send serious cases, which is in the Trècheville Hospital Center. Next slide, please. Regarding the immunization campaigns, is part of the routine vaccination, which is made at 9 months old. And for travelers, it's actually made by the Health National Institute. And during this routine vaccination, it is free, but for the travelers, it is not free, it's paid. Next slide, please. Regarding the vector fighting the vectors, we have the destruction of breeding grounds, which whether it is extra or intra domiciliary. And we have agents intervening in neighborhoods, public spaces, and homes where cases of yellow fever have been identified. We also have in Abidjan a special operation of recovery to recovery of used tires and fumigation. And this control against vectors is integrated with the malaria control programs and its activities. Next slide, please. We also have an entomological surveillance by catching mosquitoes at entry points. And then we also are doing a mapping of the breeding sites for mosquitoes. Next slide, please. Regarding the community involvement, during the epidemics, we really do a capacity building of all national actors and within all the health districts. And we also strengthen mass communication, whether it is in the radio, television, social media. And also, we organize caravans, for example, in order to target markets. We also try to implicate religious leaders and elected representatives in order to help raising awareness. But during an epidemics, unfortunately, it's really hard to mobilize the funds in order to continue this raising awareness in this way. Next slide, please. Regarding our challenges, we have challenges because we have a late detection of epidemics because of the long confirmation procedures. Because when we have cases that are positive at the lab level, we have to send the samples to the regional reference lab, or for example, to Dakar for confirmation. And often we receive the results quite late. So the epidemics are declared a little bit too late. Regarding the management of patients, we don't really have financing of funds for complementary examinations when the case is very severe. When it's an epidemics, the funding is free. But if we are not in an declared epidemics, then they are not taken into, they're not free. We also have the procurement of reagents and the case investigation. It is often very hard when we are not in a declared epidemics to really mobilize the funds to investigate the cases properly in each of the different districts. And when we have confirmed sporadic cases, normally we vaccinate for immediate response around those cases. And in the next case, we have to find free vaccines in these cases.
Now, for the perspectives, we need to reinforce the diagnostics by labs. We also need to train personnel and investigate deeply the cases in order to really fill out the notification sheets. It's very difficult to fill in these sheets because very often the documents that are sent to us in the central are not fully completed. And in particular, the phone number, in particular in an urban setting, the patient's numbers are not written down, and this is quite an issue in order to trace the patients. And the entomological survey needs to be quite reactive. Often the equipment is expensive, meaning it's difficult to carry out the survey for all cases. We need to construct a stock, a reserve of yellow fever vaccines in order to be able to respond immediately. Next slide. I think this is the information that I wanted to share with you regarding yellow fever in Ivory Coast. I thank you very much for your attention.
And we thank you very much for your presentation. Thank you, Dr. Millian, for that excellent overview of the Côte d'Ivoire experience. Again, another reminder to participants that we're gathering questions in the chat and we'll consolidate them and circle back at the end of the presentations for discussion. Our next speaker is Dr. William Wachuku from the Nigerian Ministry of Health, and he's going to talk us through lessons learned from the yellow fever readiness simulation exercises that they conducted. So with that, over to you, Dr. Wachuku.
Good afternoon, all. I hope you can hear me clearly. My network is not stable.
We are able to hear you, Dr.
But I will try to
Wachuku.
be slow so that you can catch up with me. This presentation is based on the simulation exercise that was done in 2018. Some of the lessons learned and the gaps, as well as some best practices. Thank you. Next slide. So West Africa is regarded as highly vulnerability to outbreaks of infectious diseases. And Nigeria being classified as one of the high-risk countries for yellow fever. Going by history, the first urban yellow fever outbreak in Nigeria was recorded in 1864 in Lagos, which was one of the first urban yellow fever outbreak experiences we had. So there have been multiple outbreaks up to 1996, when Nigeria recorded no outbreak till 2017. So in September 2017, we recorded the first confirmed case of yellow fever in Nigeria after 21 years of no confirmed outbreak. And in that outbreak, we recorded 40 confirmed cases with more than 10 deaths. So most of ECOWAS countries are located in moderate and high-risk areas of yellow fever. Considering the above, the West African Health Organization WAHU considered a regional simulation exercise in Nigeria. Next slide. The general objective of that was to strengthen preparedness and response capacities of ECOWAS countries. Specifics are: 1, test the effectiveness of preparedness and response measures of Nigeria in the yellow fever outbreak. 2, strengthen the capacity of individuals and institutions to carry out planning and responses to yellow fever outbreaks. 3, to strengthen partnership, teamwork, and multi-sectorial collaboration among member states, and to share the major conclusion and lessons learned from this exercise with key partners. Next slide. So the scope includes detection capacity of surveillance system, including notification and early warning of surveillance system, planning for national and regional response to the outbreak, capacity for social mobilization and risk communication during the response, and capacity for communication and coordination with neighboring countries and management of border areas. Next slide. So the method, there was advocacy to all the necessary government agencies, originated from the WAHU. Our focal person for that was Dr. Lukosu. He is present in this meeting. So it was done in 3 phases. The preparatory phase established a core technical group to conduct the CIMEX. Then the simulation phase, which was 2 days of CIMEX exercise, CIMEX proper. And then post-simulation phase, which was a 1-day after action review, including comprehensive debriefing, recommendations, reporting, and dissemination in various networks. Consultants recruited to support both WAHU and Nigerian Center for Disease Control in that projects. Next slide. Okay. Okay, so it was, the exercise was multi-agency, multidiscipline partnership activity. So from the Nigerian participant, we had the federal agencies, in addition to NCDC, we had the arbovirus team, we had the MPSCDA, in short, down to the state and the academia, they were all fully involved. And technical partners are also mentioned here, with WAHU being the coordinator. And other ECOWAS member states were also present during the exercise. Next slide. So the implementation process took this way: the planning phase, the material development phase, the setup of the exercise, the conduct of the exercise itself, and the results and follow-up of the exercise. So this spans through the pre-exercise, the exercise, and the post-exercise. Next slide. So what are the lessons learned? Part of the lessons learned includes many participants had their first opportunity of simulation exercise. The exercise was well received, well structured, and organized. Participants appreciated good preparedness plan and testing the plan. Identify strengths and gaps in our understanding of the emergency response system and plans. The four-corner exercise also provided useful insights, and the four-corner has this to evaluate what I enjoyed, what I did not enjoy, what I learned, and what I will do differently. So participants made these observations, and all of them were all recorded. So identify strengths, opportunities, and challenges, and agree next steps. Next slides. So some of our best practices, the coordination, there was effective coordination and collaboration among the partners in the. There was experienced and knowledgeable EOC staff and also in the fields. Flexibility of the teams to adapt to the scenarios played quickly and accordingly. The incident manager's leadership and direction was consistent and thorough. Teamwork among all team members, both in the EOC and the fields. So at the incident management system or EOC, there was good planning of preparation and then staffing and partnership. Strong coordination and command, clear roles and responsibilities, and timely communication were all implemented. Next slide. So surveillance, communication between the various types of the surveillance system was good. The types include the health facility, the LGA, and the states, as well as the national level. There was effective collaboration and prompt response of clinicians and the surveillance system. Good IDSR reporting system. So from the lab, code chain was maintained in the laboratory. Biosafety cabinet was also used, clean and maintained. Third, the packaging process for shipments is well known and understood by staff. Next slide. Still on best practices. Availability of the arbovirus center with trained entomologists. Prompt response from the entomology unit following the requests. On the land border, a public health emergency contingency plan was in place. Good communication between the semi-border port health team and the DSNO. That's the Badagry local government area. And semi-border has a good isolation area. In terms of case management, there was availability of infectious disease hospital with trained staff and other logistics supplies. There was effective communication between the emergency unit and the holding area where the patient was initially taken to. Next slides. So as part of the gaps we had during the CIMEX at the incident management system, limited SOPs, standard operating procedures, and templates for the EOCs, agendas and terms of reference and operations. Some of these things were not clear. No contingency funds and inadequate IT infrastructures. In entomology, there was inadequate preparation to the fields since terms of reference, data tools, and other documents were not available. And no entomologists at the subnational levels. Next. So surveillance, weak and delayed in activating the rapid response and field investigation activities. We noted poor knowledge and awareness of surveillance system and notifiable diseases among the healthcare workers in the facilities. We also noted weakness in communication, documentation, and updating outbreak information between surveillance and rapid response teams. So on the land border, we noticed that no standardized health screening processes at the border. Absence / inadequate standardized tools for response by the port health services and the surveillance system. Laboratory suboptimal waste management system was noted, and there was laxity in the coordination of yellow fever reagents supply chain. Delays in diagnosis due to inadequate capacity for real-time PCR testing in Nigeria and release of results from IP Dakar. No standardized reporting template between the national laboratory and the regional laboratory in Dakar. Case management, delay in retrieving laboratory results, initiating treatment for the patient and patient relatives counseling. We noticed that the patient relatives, the patient as well as the relatives, they weren't counseled. And this was brought forward and it was discussed during the exercise. Next slide. So the next step, there was a post-simulation debriefing and review of guideline meeting in Lagos. So there was finalization and production of yellow fever preparedness and response guideline. There was outbreak preparedness and response activities. Some of these things, as part of the evaluations that we did was the after action review meeting following the outbreaks in 2019. And also cross-border meeting was also initiated during that process. In conclusion, CIMEX is one vital component of our preparedness strategy in West Africa, be developed in accordance with the organization's strategic priorities by identifying the key capabilities most critical to the achievement and form an important part of emergency risk management. Opportunity to learn from our health systems and advocate to the relevant decision makers. Next slide. So we acknowledge the WAHU and all the partners that we are instrumental in the success of that CIMEX exercise. Thank you.
Thank you very much, Dr. Wachuku, for that presentation. And we will be sure to collect all questions in the chat and circle back to you at the end of the end of the series of presentations. And for our final speaker today, I'd like to turn it over to Dr. Peter Ibonge Mbonji. Sorry, Peter, I'm stumbling on your last name today, from WHO headquarters. And Peter is going to take us through the guidelines for developing preparedness, readiness, and response plans for yellow fever in urban settings. Thank you.
Thank you, Sydney. Good afternoon to all, and thank you being here today. So my name is Dr. Peter Mbonji. I'm sitting as Health Emergencies Officer at a Secretariat in WHQ. Yes, now I'm going to present, but I would like Jagani to come back to the beginning of the presentation because that's the last slide. So I'm going to present the guideline for preparedness, readiness, and response planning for yellow fever urban outbreaks. We'll go through the following plan. We'll just start with a brief introduction and background context, then go through the objectives and the methodology. We'll then get into the structure of the guideline, notably the urban resilience component, and see how their core elements should be organized in the planning process. Finally, we will raise some perspectives and way forward. Slide, please. So the rationale around the yellow fever outbreak issue is quite clear that the existence of a wildlife reservoir makes the yellow fever almost impossible to fully eradicate. Furthermore, the high risk of international spread makes yellow fever a threat to global health security. Can you move the slide forward, please, until you get to the, okay, that's fine. Thank you, Jagani. So on the other hand, the rapid urbanization means an increasing risk of wide propagation with risk of large urban outbreaks of yellow fever. And that is exactly what we experienced in the Angola outbreak in 2016, where yellow fever spread to other countries, highlighting the limits of the preparedness and readiness to respond to large-scale yellow fever epidemics in urban settings. However, as we know that yellow fever is preventable by vaccination and vector control outbreaks, outbreaks can be eliminated if detected early, anticipated, or responded efficiently. So that statement is exactly what led the recommendation from the A strategic plan in its objective number 2, which is to prevent international spread. Prevent international spread by building resilient urban centers, and also through the objective number 3, which was about containing outbreak rapidly by strengthening early detection, timely vaccine supply, and immediate response to outbreak. Therefore, whatever the level of risk to face the yellow fever outbreak in their urban center, be it high, moderate, or potential risk, countries should be prepared to respond to yellow fever urban outbreak by developing active preparedness, readiness, and response plans. Slide, please. So the objective slides, please. Hello, Jogani. The objectives of this presentation and this is to first of all understand the urban resilience for yellow fever, to describe the technical guidelines to develop preparedness, readiness, and response plan, and then to identify priority area of support to countries for implementation of the yellow fever urban resilience plan. Slides, please. Getting to this final document that we are presenting today has been done through specific steps and activities. And the first one was to conduct a landscape analysis, which was about conducting an analytical review of relevant documents and grid literature on urban yellow fever outbreaks. Then we conducted consultative meetings with technical experts, regional, global, country experts in different components of the yellow fever outbreak management, in urban risk, in health emergency preparedness and response, and many other areas that are covered by outbreak management. Then we got to the development of the first draft guideline by end of the year 2021, which was presented.
One second, Peter. Apologies for interrupting. Could you speak a little bit louder? We're having a little difficulty hearing you.
Yeah, okay, no problem, Sydney.
Thank
I will listen. So the first draft was presented at the annual Yellow Fever Partner meeting last year. Following that event, the guideline was tested through a tabletop exercise organized in December with about 40 participants coming from countries, from regional offices, from different technical and financial partners. And that tabletop exercise led to recommendation. And with a second wave of technical expert consultation that were conducted early this year, the guideline was revised. Slide, please. Then from, the revised draft of the guideline was sent to multi-sector panel, a multi-sectorial panel of country, regional, and global level experts for review. And input from those experts were compiled and incorporated to make the final draft, which we are presenting today. Slide, please. So the guideline has three main parts. First, the analytical review of urban yellow fever landscape in countries with outbreak experience. Secondly, the guiding principle for the development of preparedness, readiness, and response plans to yellow fever outbreaks. And then the framework for urban resilience of yellow fever. Slides, please. So the first part of the document concerning the analytical review of yellow fever landscape in countries with outbreak experience exposed the epidemiological analysis, anything about challenges, gaps, and current situation of the detection, confirmation, and response, urban outbreaks, and other Aedes-borne diseases. So it was very interesting to notice from the literature how other Aedes-borne diseases like Zika, chikungunya, or dengue are really overlapping. I mean, the areas where they are present are overlapping with the yellow fever. There was also a review of vector surveillance and control so far, how it is organized and managed so far. An interesting review also shows how countries or urban centers are likely to be at different stages of preparedness to yellow fever urban outbreaks, depending on the country situation, which makes them a development at different level. So preparedness and response planning was also addressed in this review, and then we had to check also the existing emergency and disaster management plans relevant to urban settings. And we have to say that this review of existing disaster management plans showed us that yellow fever was not really taken as a particular plan in countries, and countries were just reacting whenever there was a yellow fever outbreak occurring. So this brought us, slide please. Slide. So this brought us to anticipating organizing. Please come back. Yeah, to anticipate and organizing the guiding principle for development of preparedness, readiness, and response plans. This was organized through three major components for urban resilience that were preparedness, readiness, and response. So preparedness was really to ensure that the system and plans are in place at national level for detecting outbreaks. Then we had the readiness to make sure that we have all the necessary means available to implement systems and plan, and the response, including the recovery phase, which is about implementing systems and plans to respond to outbreaks. So each of these components were then broken into 9 core elements, which were coordination. You can go forward, please. Slide. Leadership, risk assessment, surveillance, vaccination, vector control, up to monitoring and evaluation of the response. So the idea of the main principle of the guideline was really to see how these 9 core elements can be organized for each of the components, meaning how the core elements will be organized for preparedness, how they will be organized for readiness, and how they will be organized for response. Slide, please. So having said that, the first core component, which is leadership and coordination, then had four subcomponents, the first one being legal and regulatory requirement. So in the preparedness phase, we had to make sure that legal and regulatory requirements are developed and are really showing what is required officially, legally, to implement yellow fever action. This was mainly to make sure that we have a regular and legal frame and response that is organized. So having this requirement developed and available was exactly what the readiness would have seen in that area. And then during the response, we will check and see whether the compliance to check the compliance of the response plans with the legal and regulatory requirements document. So the second sub element for the leadership and coordination was the Emergency and Operations Center, including the incident management system. So again, we had these three components. In terms of preparedness, was really to make sure we have a good description of the EOC and IMS structures and functioning mechanisms. So having those documents set and well described will make us sure that we are ready to respond. And during the response, we just go for activation of EOC and set the IMS if it was well prepared and already well designed during the preparedness and readiness phase. Slide, please. Again, regarding the leadership and coordination core elements, we had two other sub-core elements like coordination of stakeholders, which is very important, including technical and financial partners, which is about really making this work during the preparedness phase in identifying and setting a network of appropriate stakeholders and draft the partners coordination mechanism. So having done that, we could make sure that we have a good mapping of partners and all the TORs about how their coordination should be organized, which means that for the readiness plan will be there. And then the response will be the collaboration framework that will be set, and then the mechanism for partner support and engagement. The last sub-element of this leadership and coordination was the resource mobilization, which was about mapping all the resources and make sure that we have this map of resources available and we know where to mobilize or where to get to address the gaps when the response will come. Slides, please. So the same exercise was going for risk assessment, actually in terms of mapping all the areas of vulnerability. It was mainly to understand the exposition of the population, as this is a major step for the protection of this population. So assessing the vulnerability was done based on epidemiological history and environmental context of the area. Once we have it, could say that the readiness checklist will have it, and then the response, the risk assessment during the response will then be a thorough situation analysis or in-depth investigation. Slides, please. So as regards the risk assessment, this is an example of a mapping of the risk using a risk score, and where we can see in brackets in front of country names, what is the risk score of each country. So if you see the colors, you will see that the risk scores that are between 30 and 45 are really in the dark color, and then it goes up to the light colors. So from there on, we can imagine what will be their risk in each area. I mean, what will be the percentage or burden of the disease in each area if it arises, and it helps organizing the response. Slides, please. After the risk assessment, then we go to surveillance. We go to surveillance. For surveillance, again, this core element, we have four sub-core elements. We have epidemiological surveillance that we need to address during preparedness, make sure that all the plans are ready, and then organize when it comes to response, organize data collection and sharing, and work out information products and secret. Then we have also another point of surveillance with the entomological or vector surveillance, which will also be addressed for the three main components of the outbreak management. Slides, please. The third surveillance point is the laboratory. It's very important to have a lab network, and which is well designed and which is really communicating with the other surveillance element. Then the fourth surveillance element is the surveillance at point of entry. We will notice that there is another entomological surveillance. I talked of it before, yeah. So the last element of surveillance is the point of entry, and that's where we need to make sure that all the international health regulation requirements are in place to capture or to detect any case of yellow fever entry in the country. Slides, please. So the next core element is vaccination. Vaccination, we know that a single dose of vaccine provides long life protection, and we know that only one of the main elements, if we want to eliminate yellow fever, is to make sure we increase the vaccination coverage up to 80 or more %. So a vaccination campaign is very important, but as we are moving from preparedness to response, we can consider different stage of vaccination. For preparedness, we should make sure about routine immunization, and then when relevant, we can do preventive mass vaccination campaign. At times, there is also a possibility to do a combined vaccination strategy, which can be put in place during preparedness. So, but anyway, we should always make sure that during on our readiness checklist, we have all the requirements for a reactive mass vaccination campaign to be organized. So all the vaccines should be available. All the deployment requirements like logistical and so on should be identified, and a good plan should be said to be implemented.
بحيث يكون البرنامج جيدا. بعد ذلك وبعد اللقاح لدينا التدابير الخاصة
de la vacunación que debe de considerarse también para
la fièvre jaune. Il faut vraiment surveiller toutes les espèces de vecteurs. Et cela peut nous permettre de ralentir vraiment la propagation de la maladie. Prochaine diapo, s'il vous plaît.
Yeah. So the case management now is also another issue because as we all know, there is no specific curative treatment. So we just have to take the symptom, but it's very important in the preparedness phase to develop, some protocols, some clear protocols on how to detect and take over. Also, there will be it will be a good opportunity to develop some reference set where to refer with a specific center working with yellow fever patients. Slides, please. So the risk communication and community engagement. This is also another part, as we know. The mosquito breeding sites are mostly in the community, so it's very important to inform and educate the population in terms of prevention and risk and so on. So this should start during the preparedness, where all the population at risk are identified, the gaps of knowledge are identified, and then we can develop communication scheme of strategies and material. Once those are developed, we can check our readiness checklist, and then where if ever we have an outbreak, then we can just implement the communication, draft the communication framework and implement. The slides, please. Yeah, before the last, we have the 8th core element, which is continuity of service. This is mainly about 2 points: the continuous access to health services, which is actually to consider health system strength and actions for each component of the health system in emergency situation, and to make sure that even if we have an outbreak, the access to health services will be continuous. So during the outbreak, there will be an analysis of health systems needs, and then there will be a need to reinforce each of the health system components. The second part of the continuity of service is more about continuity of healthcare, which is actually to put in place a mechanism for follow-up of cases. As we know, in many communities, people suffering from this disease are sometimes not coming back to the hospital just because of stigmatization or things like that, or even belief can divert them from the hospital. So it's important to put in place a mechanism for follow-up of different patients to organize for home or community care. So this strategy of continuity of care will be developed during the response, and this will include also the implementation of home services. Slides, please. So last but not least, we need to follow up all the implementation of these plans. We need to have indicators for the monitoring and evaluation, and then to develop a plan so that we make sure that our preparedness, readiness, or response planning are well monitored to always address the gaps that may arise during the implementation process. Slides, please. So, as regards the readiness, it's important to notice that in this guideline, we are also presenting a preparedness and readiness checklist that was developed as a set of activities that needs to be completed before an outbreak occurs. So this is very important as well, because if a country can adapt it, because it should be contextualized, it will really help to assess and test their level of preparedness and readiness for an effective urban yellow fever outbreak response. Slides, please. So the best way, yeah, there is another slide in between. Yeah, no, sorry, we don't have it. So the best way to address this is to go through a simulation exercise to test the system, is to go through a simulation exercise. This simulation exercise will assess the readiness of the country in all the core elements in preparedness, the response to yellow fever outbreaks. It will also help reviewing preparedness and response mechanism at the national and subnational levels, but also update the preparedness and response plan and build a strong resilience system to yellow fever outbreak in urban center. So the next slide, please, will be now the third part of this guideline will be the framework for urban resilience. It's mainly about a summary of all the important elements and steps at different levels, including preparedness, readiness, and response to urban yellow fever outbreak in a one-stop shop. And then it helps also designing to help guiding. It also designed to help guiding assessments of the management of urban yellow fever, and eventually guiding the action plan. Slides, please. So having presented these guidelines, it's important to notice that from what we have seen from countries, there is really very, very, very few countries in the African region, which is the most exposed, but even in other regions that have developed such preparedness and planning and response plans to yellow fever outbreaks. So it will be important at the next page to mobilize all the efforts in terms of providing technical support to countries to having these plans developed if we really want to end the disease by 2026 as the IA strategy recommends. And by doing that, it will also be important to organize at least one simulation exercise periodically in countries to assess systems and plans in place and increase the level of readiness for urban yellow fever. Yeah, I think that's what we could present to you today. My name is Dr. Mbonji. Thank you for your kind attention.
Thank you, Dr. Peter, for that presentation, and thank you to all of our speakers. So this brings us to the end of the formal presentations and opens the floor for questions from all of you participants in the chat. And we've received a couple so far that I would like to open up for all the speakers to input into. The first question is regarding stakeholders, and the question is, during the process of preparedness for yellow fever, and I think especially for the Nigeria team and Dr. Mbonji, what key stakeholders do you as a yellow fever representative see developing a relationship with? So through this process, what stakeholders have you developed closer relationships with, or would you recommend other teams develop close relationships with to better facilitate the process?
Excuse me, Cindy, I did not get you well.
Yes.
Can you quickly say it again?
Gladly. So to strengthen preparedness and readiness, what stakeholders, so what partners are critical?
Well, yeah, if I may answer to this, I would say it depends of the partners present in the country. The core element guide us towards the different areas that are very important. So like epidemiological surveillance, we have a lot of partners that are working towards surveillance in terms of training, in terms of supporting or designing tools and so on. It's all those partners working on the health information system, on the epidemic surveillance, on the outbreak management and so on. So this is one thing. As regards coordination, I think all the partners working around coordination, meaning financial partners, but also high-level technical partners that are present in countries, they should all be part. And we should not forget that when we are talking about partners, we should also think about other sectors within the country that are also partners with the Ministry of Health. And I'm thinking about all the social ministers of social affairs or things like that, where or maybe health determinants that should be taken into account, and so on. I think these are people we should bring around the table to work on. So I would say that each of the components mirrors some specific partners. As you know, for immunization, for instance, you have many programs around the world, Gavi and so on, that are working on it. You have some other UN agencies that are working on immunization. WHO is there covering almost all these fields, is one of the most cross-cutting agency. But for each of the components, for communication, you have some different partners and so on. But it's very important for all those to work together. This is the main message. One of the problems we have noticed in countries, it was like a lack of communication between, first of all, some different units within the same sector, like immunization, having a very strong involvement in the response, but also epidemiological surveillance or outbreak management units having a strong involvement. And at times we even forget that entomological services for vector control are not really fully part of the health sector. So at times it's also important to get them involved. Research and academics are working towards controlling vectors, mosquitoes, and so on. So I think it's important to consider each element and to bring together different partners that are working into these different areas. I hope I gave that, but anyway, anyone can also complete what I've said. Thank you. Over to you.
Thank you. Yes, that is a very comprehensive answer. Thank you for that. And a good reminder to include our entomology, having trouble this morning, entomology colleagues as well in the discussion. Wondering if any of the other presenters would want to weigh in, perhaps colleagues from Cameroon or Cote d'Ivoire on either that question, or there was actually a question in the chat specific to Cote d'Ivoire that I will put in the chat again for quick reference. And we have a follow-up question from Frederick, again to you, Dr. Peter. So thank you for highlighting the need to strengthen surveillance vector control capacities and reiteration that at the Global Vector Hub, they're keen to support the efforts. So that is encouraging. And for the Cote d'Ivoire team, could you please go into a bit more detail on the detection of the 89 IgM positive cases for 2019 and how that led to a conclusion of it being non-epidemic? That is a question again to the Cote d'Ivoire team. Over. And it appears.
Ok, je peux répondre.
Yes, I can answer. Just to be precise, indeed, it was an outbreak, but with the help of the WHO, we concluded that we can't do a vaccination response because we have a few crossed cases. We've had only 10 cases that were IgM positive and yellow fever, and therefore a majority was vaccinated. And therefore we concluded that we couldn't do a reactive campaign. Thank you very much.
Wonderful. Thank you for that clarification. Very much appreciated. So I would like to go ahead and open up the floor for any additional questions if participants would like to ask directly. We have approximately 5 more minutes, so I'd say space for one additional question. And in the absence of that, I think, yeah, Dr. Emily.
Oui, je vous écoute.
Oh, I thought,
Listening.
my apologies. I thought you went off mute to say something, but it appears that we've answered all the questions so far in the chat. And I just want to thank our speakers so much. We are going to have to wrap up now, and I would welcome any additional questions in the chat or via email. We can circle back to participants at a later date as a follow-up. We will also go ahead and share the presentations that you've seen. And I just want to say again, a big thank you to our speakers, and that we're very honored to have you here with us today. And to our participants, thank you for making time for this call. And lastly, we can't forget our interpreters who facilitated making this a truly global conversation. And we really do appreciate your time and all of your assistance. So thank you for making this webinar so successful. And we look forward to connecting with you again soon. Bye-bye.